First of all, in the current world, almost 80% of cancers can be treated minimally invasively, which means you can open 3-4 holes in the abdomen and 1-2-3 holes in the chest, and you can get the whole tumor out and do the reconstruction. So esophagus is a very interesting organ. When you take out the esophagus, you need to replace it with another tube. It is not possible, like in small intestine or large bowel, to cut in between and then suture together. So you can take out, if you take out a 5-centimeter piece of esophagus, you need to put as tissue either a stomach tube, which will be like esophagus, or a small intestine or a large intestine, to replace the defect in between. So if you don't do it, we cannot simply suture esophagus together. This is not possible because of tissue characteristics. So what we do typically is, in cancer cases, in over 90% of the cases, we use gastric tube. We take the large side of the stomach on the left side, which you see in the figure, and we make it a tube to actually make it a very long tube that can even reach up to the base of our neck, up to we describe it for the patients, it can come up to the tongue, the end of the tongue region. So the stomach can become a very long tube. So we can actually take out the whole esophagus, part of the stomach, and then actually take that stomach up to the neck or chest, and then suture the remaining tissues together to preserve the gastrointestinal continuity. So if somebody, again, with this operation, the patient will be able to eat eat any kind of food with some slight dietary restrictions, but most of the patients can pretty much eat everything in small portions.